the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
A very warm welcome to all our participants. Welcome to another lecture of the series, Paradigm Shift Towards Holistic Health and Women. Today's topic is Adolescent Pelvic Floor and Issues, Catch Them Young. Our chairperson for the day is Dr. Abha Dhupkar ma'am. She has done her Masters of Physiotherapy from MS Ramaiah College of Medical College, and she's currently working as Associate Professor in DES Brijla Jindal College of Physiotherapy. She has 12 years of experience, and she has also done her Masters in Hospital Administration. It gives me immense pleasure to welcome you, ma'am. And the speaker for today is Dr. Rutuja Kowale. She is Masters of Physiotherapy from D.Y. Patil College of Physiotherapy, Pimpri, Pune. She is currently working as Assistant Professor in DS Brijla Jindal College of Physiotherapy, and she has 7 years of academic experience with 3 years of clinical experience. A very warm welcome, ma'am, and we are eager to hear from you. Handing over the session first to Abha ma'am.
Thank you, Farheen. Am I audible?
Yes, ma'am.
Okay, I'll just share my screen and we'll start immediately. Is the screen visible?
Yes, ma'am.
Yes. Apologies, everyone. I'll not be switching my video on because I'm slightly sick, and you are, as it is, going to have to listen to this voice for a few moments. Thank you, Sanjeeti Healthcare Academy, for bringing out this topic, a paradigm shift towards holistic health in women, and especially thank you for bringing out this more important topic of adolescent pelvic floor and issues, catch them young. I'm Abha Dhupkar. I'm an associate professor in DG Society's Brijla Jindal College of Physiotherapy. For today's session, we'll be looking at the adolescent pelvic floor. We'll be looking at the common issues that are faced by adolescents and common issues that we as physiotherapists are going to be facing. So the first thing is what we will be looking at is what we will call an adolescent. Who can be called as an adolescent? If you look at different people, you'll be getting different perspectives. The dictionary meaning is someone who's not a child and someone who's not an adult. And that is the actual dictionary meaning across different dictionaries. If you ask a parent, it's going to be someone who's going to be throwing tantrums for no reason, but who's as yet not a child and who's as yet not an adult. Basically, why is this going to happen is because there are a lot of changes in puberty which are going to take place. And you can see a depiction over here. So there are going to be physical changes, there are going to be psychological changes, physiological changes, as well as hormonal changes, which are going to drive this whole period of a person's life. So in this, we are going to be facing certain issues. And the common issues that the adolescent is going to come out with are what are these issues that we are going to be talking about? Are we really supposed to talk about them? Because they are going to be facing some embarrassment. They are going to be having some inhibitions to talk about the very important issue about pelvic floor health. And the next thing that they're going to be thinking about is, isn't this normal? Because no one has told them what is normal, what is not normal. And therefore, they will always be having this issue of whether the issue that they're facing is normal or not. And the last one, and which is very important, is they don't know whom to talk to about these issues. So let's look at the issues. First, the ladies. We'll be having a quick, short look at what gents face, as well as non-binary and the special populations. But the whole focus of this today's topic is going to be on what females are going to be facing and the issues that they are going to come ahead with. So what are the issues that the ladies are going to be facing? So they're going to be across a whole spectrum. We'll be getting musculoskeletal, bladder function or bladder dysfunctions, menstruation and related dysfunctions, genital region and related dysfunctions, especially uterine and bowel functions, which can get affected, as well as sexual functions. Even if whatever society we are in, this is the period for children, or this is a period for individuals to start exploring their sexuality. And whether we like it or not, this is one of the functions that they are going to be talking about at this point of time. They are in the ages of 13 to almost 18, and they will be exploring sexual function a bit. And therefore, we need to talk about this. And then we have the assault or abuse survivors, which are a completely different category by themselves. When we look at what the gents are facing, what the boys are going to be facing, they'll be having prostatitis or chronic pelvic pain syndrome, which is now termed as prostate pain syndrome, incontinence, constipation, and again, they are also going to be facing sexual dysfunctions. For the other populations, nowadays, we don't look at just male and female genders. We also look at non-binary individuals, and we do have some limitations to the knowledge about non-binary individuals. We have children with disability who are going to now progress towards adulthood. And for them, the issues are going to be really difficult to handle because they show signs of puberty early. Also, underlying neurological causes are going to manifest as pelvic floor dysfunctions. And then we also have sports people, and this is a really special population for us because children are going to now, they are now going to progress towards adulthood with the type of training that they're undergoing. They're likely to end up with pelvic floor disorders. And this is quite commonly seen with high impact sports like football, basketball, even runners. And this is very, very commonly seen in gymnasts. So we will be looking at what we can do for these people as well. Major issues that we as physiotherapists are going to face are problems with physical examination, problems with patient interviews, and also referrals. Who's going to refer these children to us? Whom are we supposed to refer ahead if we face an issue which we cannot tackle by ourselves? Because we are going to be working as a multidisciplinary team over here. It is not just the PT who's going to be working alone. Therefore, we have to look at these issues that we as physiotherapists are also going to be facing. To start off, therefore, I will be calling upon Dr. Rutuja Kowale, my colleague over here, and she will be continuing ahead with the discussion. I'm just stopping this sharing so that she will be able to share her slides. Rutuja, over to you.
Hello, am I audible to everyone?
Yes, ma'am.
Okay, first of all, Fareen, thank you for such a nice introduction. And it gives me immense pleasure to be a part of this webinar. And thank you, Sanchiti, for giving such a wonderful opportunity for exploring this topic, which really has to be given an importance. So here we continue. Okay, am I PPT visible?
Yes, ma'am.
Hello.
Yes, ma'am. We are able to see your screen.
Okay. Before we start, actually, I'm assuming that we have an idea about what is exactly the pelvic floor, which muscles. Okay.
Otherwise, I'll keep on copying.
Yeah. Okay. So first, we'll give you a small, very brief introduction about what does the pelvic floor means and what is the muscles which are included in pelvic floor. So we are not going to go into the details of this topic because we have many important things which needs to be explained. So first, we'll see that the pelvic floor are the muscles which run across, and the main function of the pelvic floor is to hold up the various organs, that is to provide support to the pelvic organs. Majorly it includes bladder and bowel. Normally the issues that arise with the pelvic floor is that if this particular groups develop a weakness, then there can be the issues which are developed, or there are many other also reasons which we term as the pelvic floor dysfunction. There is a big misconception that normally only the pelvic floor disorders they arise after the pregnancy in the woman. No. As far as considered as the number of women involved with this particular disorder is equal to the number of men also involved. So this topic has to be given importance in both the point of view, that is the female pelvic floor disorders and the male pelvic floor disorders. If you see, there is one female called as Dr. Olivia, who is a urogynecologist in Mayo Clinic. She has said that every 1 in 3 women over the age of 20 report some pelvic floor dysfunction. But because of this age, that is adolescent, they are not able to freely communicate with us, or maybe they are not aware with whom we should communicate, because there might be some embarrassment which might refrain them from bringing into notice if some problems associated with pelvic floor are faced. Okay, so this is the basic anatomy. There are 3 layers: superficial, deep, and pelvic diaphragm. So in superficial pelvic floor layer is innervated by pudendal nerve. Deep is also innervated by pudendal nerve, and the muscles included are bulbocavernosus, ischiocavernosus, superficial transverse perineal, and external anal sphincter. And deep urogenital diaphragm, there is uterovaginal sphincter and deep transverse perineal and compressor urethra. These both layers are supplied by the pudendal nerve. And the third comes the pelvic diaphragm. It is innervated by the sacral nerve roots from S3 to S5, and it includes levator ani, ischiococcygis, piriformis, and obturator internus. So this is the basic anatomy of the pelvic floor, which we are everyone quite well acquainted with. So now we are also aware about the role of the pelvic floor. So just I'll give you a brief introduction about what is the major role which pelvic floor muscle plays. So in females, it gives you support and tone to the vaginal wall, supports pelvic organs. Then if there is increase in the intra-abdominal pressure, it maintains anorectal angle. Then there is a relaxation for the defecation. Then it has an inhibitory effect on the bladder activity, then prevents incontinence. Incontinence is of 2 types, that is urinary and fecal, that is a bowel incontinence. Then allows for the opening of the pelvic floor to accommodate expiratory functions, that is the relaxation and contraction. Both processes are done by the pelvic floor. Then reinforce urethral closure during increase in the intra-abdominal pressure. and assist in unloading the spine, assist in pelvic stability, and contribute to sexual arousal and performance. So see, the role of the pelvic floor is so major in our life that we have to really take care of this particular muscles. So now, normally, if you face any issues, there is a basic protocol where you need to evaluate to understand that the particular female or male is suffering from the pelvic floor issues. So what assessment majorly you're going to do is, first you're going to ask for the symptoms. While taking any symptoms, it is very important to know the priority or the importance of the symptoms. I mean, what patients do, they don't tell us everything. So it is our duty or it is the doctor's duty to know exactly what the individual is suffering from. Second thing which you're going to take is relevant obstetric, medical, gynecological, and surgical history, because among this you can find out the what is the reason for the pelvic floor issues. So this history is very important. Then, if the patient has done with any investigations or the patient has taken any previous treatment or currently the patient is under any treatment, that is also very important to be known by the treating doctor. Then fourth will be the details of voiding dysfunction or if any incontinence is there. Then you can take those details from the frequency or volume charts normally which we study in urinary incontinence. And then there is a rectal function defecation pattern. All these things are very important to be known for us to come to a proper conclusion or a diagnosis. Then there are objective. Besides this was all the history part. Now we'll go for the assessment part. I think we are quite aware of the maximum of the procedures which we go for the assessment of pelvic floor. That is digital per vaginal examination, then per anal muscle assessment has to be done. Then effect of cuffing and straining on the vaginal wall. Then there is a 6-point scale on which we grade the pelvic floor contraction. Then there is a device which is called as a perinometer, which is recently very well used for the assessment of the pelvic floor, which is called as a perinometer. And there is one more technique which is called as perfect. Okay, so I'm not going to go into the details. Then there is one more test which is called as a stop test. So the stop test grades from 1 to 5. So 1, yes, grade 1 is that this has to be performed by the patient, and if possible, it is better that if we are around while performing this as per the comfort zone of the individual. Okay, so grade 1 is unable to slow the stream of the urine. If patient gives you this scenario, then you're going to grade 1. Then 2 is can slow the stream but cannot stop. Then 3 is can stop the flow of urine but has a difficulty in stopping. And 4 is urine stops abruptly but cannot be repeated. So, and 5 is urine stops abruptly and stopping can be repeated. So on that basis, on this stop test, you're going to grade the strength of the PFM. Then comes your other methods, the jumping jack test, pat test, EMG also can be done, urodynamic assessment, and pelvic floor dynamometer can also be used. So these are the 13 other ways. Besides the previous 2 slides, these are the 13 ways from which we can confirm the contraction of the PFM. So I'm not going to go into details. I think we are quite aware because we are studying since our 4th year. Okay. Now, basic thing, when a patient comes to you, there are particular sets of contraindications which are to be strictly taken care of while you go for any internal evaluation of pelvic floor muscles. That is, first is pregnancy. Then second, within 6 weeks of vaginal or cesarean delivery or any other pelvic surgery. Then if there is atrophic vaginitis, then there is an active pelvic infection. If there is a severe pelvic or vaginal pain, then in children and pre-sexual adolescents, if there is a lack of informed consent and lack of therapist training. So you have to give importance to, as far as we give importance to assessment, so it has to be given importance to the contraindications also. Okay, now this was the basic about the pelvic floor. Now we are going to see what are the problems associated with the pelvic floor that we consider it as a pelvic floor dysfunction. Okay, now see, basically to understand the term pelvic floor dysfunction is very important before we go into the details. So if you want to define, it is a very common condition right now where the patient is unable to correctly relax and coordinate the muscles in your pelvic floor to urinate or to have a bowel movement. See the here slightly you can say in simpler words that the functioning of the pelvic floor muscle is affected, which has to be normal is not there. And if the pelvic floor is not functioning properly, then there can arise a set of problems which is called as a pelvic floor dysfunction. So specifically, the organs which are included in pelvic floor are bladder, the uterus, the vagina in women, the prostate in male, and the rectum. These are the four organs which suffer the most if there is any pelvic floor dysfunction. Okay. How to explain in simpler words is that normally when we go to a bathroom with, if we don't have any issues and when we go to a washroom, so what happens is that normally you are able to go to the bathroom with no problem because your body tightens and relaxes its pelvic floor muscle. That is, a contraction and relaxation ability of the pelvic floor is intact. This is just like now how we are going to explain in a simpler form, that like tightening your biceps when you lift a heavy box or clenching the fist. If you're able to contract the muscle properly, then you're able to perform the activity in a very smooth manner. So functioning of the PFM is very important. Now, this is a normal mechanism, but if you have a pelvic floor dysfunction, now we need two actions to be normal for the normal functioning is a tightening and relaxing. But now if in pelvic floor dysfunction, the muscles of the body, they keep on tightening. The relaxing component is missing in them. So if you find such situations, then definitely we come to a conclusion that there is some issue associated with the pelvic floor, which is called as a pelvic floor dysfunction. So this can be one of the way to conclude. There are many other tests, but a preliminary way is to understand that if patient complains of this kind of symptom, then you can say that yes, there are chances of having a pelvic floor dysfunction. Now, what happens if the muscle keeps on tightening instead of relaxing? Then there is a development of tension. Yes. So what happens when there is a development of tension? Understand this. These things are very important. There is a trouble evacuating a bowel movement first. Second, there is an incomplete bowel movement, or there is a urinary or fecal incontinence. Okay. So these three things can occur. Now, basically, when a person comes to you, they can ask you, what can be a reason for the pelvic floor dysfunction? But actually, if you go through the details, the exact or the full causes are still not known. But a few factors which we can tell to the patients are that if the patient is having any traumatic injuries to the pelvic area, first. Second will be pregnancy. Third will be overusing the pelvic floor, pelvic muscles. Fourth will be pelvic surgery. Then overweight and advancing age. So these are the causes of the pelvic floor dysfunction. Okay. Okay. Now, if you ask me about the symptoms, what the patient is going to give you, or what the healthcare provider should know, or what the patient should tell us, are that first symptom will be frequent needing to use the bathroom. That is increase in frequency to go to the washroom first. Second, constipation or straining pain during bowel movements. Third is fecal or urinary incontinence. Fourth, if there is a painful urination. Fifth, there is a feeling pain in your lower back with no other cause, means no other pathology, no ortho condition, nothing. So this can be one of the symptom which you should take care of. And sixth is feeling ongoing pain in a pelvic region, genitals and rectum with or without bowel movements. If any of these symptoms are seen, then you can say that it is a pelvic floor dysfunction. I hope I'm not going too fast. Are you able to get me? Okay, shall we move ahead? Now, now I have mentioned in previous slide, as Abha ma'am has also mentioned, that as the women also suffer from the pelvic floor dysfunction and men also suffer. So what exactly the men and the female complaint, or what exactly they suffer because of the pelvic floor dysfunction, is that first there is a male urinary dysfunction which we called as a urinary incontinence. First, then there is a that is a bladder and bowel incontinence, or we can call it as a bladder and bowel issues. Second will be a erectile dysfunction, which is very commonly suffered in the men due to the pelvic floor dysfunction. And third will be prostatitis. Okay, so this is the inflammation of the prostate, which is called as male reproductive gland. So to avoid this, actually, early diagnosis of this pelvic floor dysfunction is very important, or even you can say that the awareness about this pelvic floor dysfunction in adolescents has to be done, so that they are aware and they don't feel reluctant to share what they're suffering from, because the reluctance is that which is keeping this condition really underestimated. So they should feel free to talk with the family and then with the concerned doctors. Okay, now we are going to see the diagnosis of the pelvic floor. In that we have seen about the history part. So you're going to ask about the history of urinary tract infection. Then in female, how many times she has been conceived or she has given birth, or if she has any pain during the sexual activity, that has to be asked. Then do you have any particular conditions? There are two conditions in which this pelvic floor dysfunction is seen. That is a interstitial cystitis. You know what do you mean by this? This is the inflammation of the bladder wall, and second is irritable bowel syndrome. That is a lower intestinal tract disorder. So this history has to be taken. Then do you strain to pass a bowel movement? Okay. So these are the basic things besides the objective assessment, besides the pelvic floor muscle strength and the history part. These three major and along with the investigation which the patient has done, all these things can lead us to a proper diagnosis associated with the pelvic floor dysfunction. Okay. Now we are going to see there are actually basically 4 types of pelvic floor dysfunction. So it is a supportive, hypertonic, incoordination dysfunction, and visceral dysfunction. So I'll give you a very brief introduction about this, because the patient comes with a complaint, we should understand exactly in which category the patient falls. Okay. We are going to see the supportive dysfunction. So this dysfunction is associated with the weakness of purely pelvic floor muscles. So you can say that it results from the loss of the strength and integrity of the contractile and non-contractile tissues. So if the pelvic floor muscles are weak, or if there is a sagging of pelvic floor, then it leads to a supportive dysfunction. Then if you want to see what picture is seen or what conditions do you see due to the supportive dysfunction, is stress incontinence. It can be a mixed incontinence, or it can be a pelvic organ prolapse. That is, we normally call it as a prolapse. It can be any of the pelvic organ. Okay, so these are the basic things. If you see, you can come to a conclusion that if the patient falls into the category of the supportive dysfunction. Now, when we move to the next slide, I'll be telling you the reasons for the supportive dysfunction and what impairments do you see in such patient. Okay, so etiology goes is that the reason is the anatomic impairment of pelvic floor muscle and the nerves if they're affected in the pelvic area. This is the first reason. Second will be the vaginal delivery. Yes, then third will be the muscle atrophy due to any peripheral nervous system involvement. Then fourth will be decreased awareness. If we are not aware about this, then definitely we are going to have the pelvic floor muscle weakness. And fifth will be prolonged intra-abdominal pressure. Now what happens is that if the intra-abdominal pressure increases, then there is a stretching of the pelvic floor muscle, which leads to this particular pelvic floor dysfunction. And last and very important, which is very common right now, is the obesity. So these are the 6 major factors which leads to the supportive dysfunction. We have seen what do you mean by supportive dysfunction, what are the etiologies. Now we are going to see exactly what impairments do you see in the patient. Okay, then first is impaired performance and endurance of the pelvic floor. That is, the muscle is not functioning properly. Then second is that the length of the pelvic floor muscle is increased. And third is that increased connective tissue length and muscle atrophy. And fourth reason is impaired abdominal muscle performance. Then fifth is coordination of the pelvic floor muscle is decreased. That is, the contraction and relaxation ability is not going hand in hand. So that is the coordination. Then sixth is pain in pelvic floor muscle region or pelvic floor muscle. Then seventh is mobility impairment of the pelvic joint. And eighth is symptom of incontinence. If you see any of these impairments, then also you can say that the patient falls into the category of supportive dysfunction. Okay.